Welcome to a session on neuroimaging. We'll be looking at images of the living brain with the objective to identify some of the common imaging modalities: X-ray, CT scanning, MRI, and angiography. We'll be looking at what is being measured in each of these images, the major anatomical structures seen with these imaging modalities, and some of the more common pathologies seen with these images. Neuroimaging started based on the original identification of X-ray technology, in which William Röntgen showed that directing X-rays at the body was able to reveal some internal structure, and here's the picture of his wife's hand. A source of energy, in this case X-rays, is directed towards the body and picked up by a detector on the other side of the body, and when the energy is absorbed, it will not by the body, it will not reach the detector, and the difference between what's absorbed and what's passed through the body determines what's seen in the detector. In radiology, there's a convention in which horizontal, that is axial images, and also coronal images, the left side of the image corresponds to the right side of the brain, and vice versa, as if you were standing at the toes and looking up at the head. In general, in clinical images, as in this one, you'll see that it is an indication right on the label of which side of the brain you're looking at. The images are may be available in three different planes. That is, in a horizontal plane, essentially a cut horizontally through, in this case, the head, or a coronal, and we see the horizontal plane here in the middle with an MRI, or a coronal plane or a frontal appearance, and here we see the coronal image for the same brain, or a sagittal image, which is the blue represented over here. It's essentially a cut down the midline and can be off the midline, moving gradually laterally. So we'll often have images sometimes have images in three different planes. In a skull X-ray, soft tissues in the body, blood, skin, fat, and muscle, allow X-rays to come through, and they appear dark. But bone or foreign bodies, as with these nails shot from a nail gun, or a tumor, which is much denser, may absorb the X-rays, and they'll be seen as white. In this skull X-ray of an individual who had need to have recordings from the surface of the brain, the skull had been removed, a portion of a skull flap had been removed by drilling small holes, burr holes, through the skull, connecting those with a saw so that this flap of bone could be removed, electrodes put onto the brain, and then the flap of bone restored. And what you can see here that you can't appreciate is that at multiple levels, all collapsed from 3 dimensions into 2. You have the bone, you have electrodes that are actually inside the skull, and then you have staples that are outside on the scalp, as well as wires that are outside on the scalp, all shown in this 3 dimensions reduced to 2 dimensions. In a skull X-ray, it measures X-ray attenuation. You see here bone will be as calcified and will be white. Some foreign bodies, the metallic in particular, will appear white. Soft tissue is dark. It's very good for skull fractures and for calcified masses. And you can obtain these views in both lateral and AP views. And then about 30 years ago, there was a dramatic revolution in brain imaging in which, utilizing computers, information derived essentially from an X-ray could be converted, and it would enable you to see grade white matter differentiation. It allowed tomography, that is the ability to view parts of the nervous system, the brain in particular, and the skull, as if it were just a slice of a few millimeters or a centimeter thickness. And it also has the possibility of 3D reconstruction. That began the possibility of marrying structural images and possibly functional images, combining anatomy, physiology, some chemical neuroanatomy, and ultimately various kinds of pathology. The CT scan developed in the 1970s by Godfrey Hounsfield, who worked with EMI, the sponsors of the Beatles, and Alan Cormack. They both received the Nobel Prize for this development, which was truly revolutionary, the beginning of CT computer tomography. And this is the very first image that was obtained with a woman who happened to have a suspicion of a frontal brain tumor. And you see an area here that is a little bit different in shading than in other parts of the image. You see the skull all the way around. The brain is just modeled, but you can see one area in which there's much less transmission, and that was the brain tumor. The CT scan does allow cross-sectional analysis, and you see some sample of that here. For this particular slice C is essentially a measure of brain tissue and skull at this orientation. In this case, the bone is white, as you can see here. CSF, cerebral spinal fluid, is black, as we see in the lateral ventricle right here and in the cistern. And if you were to have older blood products, they tend to be dark, and new blood products tend to be, new hemorrhages tend to be bright. We'll see samples of that. And these can be reconstructed from 2 dimensions into 3 dimensions. We see here the multiple slices through this particular brain, and we see lower down near the brain, base of the brain, we see the bony structure, as well as the frontal lobe, temporal lobe, and cerebellum. We can see the 4th ventricle here, and we see the pons, the portion of the brainstem. If we come up a little bit higher to C, we see again the lateral ventricles, as well as the caudate nucleus right up against the lateral ventricles, and we see the midbrain right here. And if we come a little bit higher, we can see the lateral ventricles again. We see the caudate nucleus, as well as the thalamus. This CT scan is quicker, cheaper, and more readily available than an MRI, and it's also particularly good for picking out strokes at certain points in time, some tumors, and is very good for assessing hydrocephalus. We see here, compared to the normal, an example of a CT scan in an individual with hydrocephalus. In this case, we see that the ventricles are enlarged. Lateral ventricle, the 3rd ventricle, the 4th ventricle, and other branches of the lateral ventricle are enlarged. We also see edema at the end of the ventricles, and we also see a tumor in the 4th ventricle, clogging up that 4th ventricle and preventing outflow of the CSF from lateral and 3rd ventricle, which should be traveling out through the 4th and then into the subarachnoid space. This is a buildup of CSF in the ventricles. We see an example here of an acute hemorrhage. These are going to be CT scans. An acute hemorrhage with surrounding edema, as well as enough of a mass effect so that this has pushed over the midline. We see here a midline shift indicated by this arrow. Here we see a CT scan for a middle cerebral artery infarct, in which there is a loss of some of the brain tissue that had been fed by that middle cerebral artery. We do see the lateral ventricles right here as well. Here's an acute ischemic stroke on a CT, and we see an altered density in the area of that acute ischemic stroke 24 hours after the stroke. If we look much later, we'll see much greater loss of tissue around a stroke, another ischemic stroke represented here. We see the lateral ventricles in these regions. A cerebral angiogram builds on the X-ray, and in this situation, a catheter is inserted into an artery, usually the femoral artery, slid up through the vasculature up towards, in this case, the carotid artery, in this case, the internal carotid artery, and then a radio-opaque material, X-ray opaque material, so that whenever this material is inserted into the vasculature, when an X-ray is shot at it, it will not go through the vasculature that has that opaque material in it. In this setting, we see the middle cerebral artery distribution over the entire lateral portion of the hemisphere, and we see the anterior cerebral artery at the midline. Lateral as well as AP views are available. This is essentially seeing 3 dimensions reduced to 2 dimensions, in this case for a right internal carotid angiogram. As we said, you can look at the AP view showing the structures we identified earlier, as well as a lateral view that shows the wide distribution of the middle cerebral artery, but this then overlaps with and we cannot differentiate middle cerebral artery from anterior cerebral artery in this image. But we can see over here on this schematic diagram with the head flipped, the very wide distribution of the middle cerebral artery. That is, all of this lateral portion of the hemisphere is fed by the middle cerebral artery, as we see represented here. When the contrast material is injected into the carotid artery, then if you take rapid pictures of the radio opacity, what you find is early on, you'll see the arterial distribution. Later on, you'll see the capillary phase. You see very fine resolution small vessels. And finally, you'll see a venous phase showing distribution in the veins and the superior sagittal sinus and various other sinuses. In a patient with a left middle cerebral artery infarct, you might be able on an angiogram to see an area in which there is a narrowing of the vessel, in this case the origin of the middle cerebral artery, seen here and here. So an angiogram can be used to identify areas of narrowing vessels. The CT angiogram can be reconstructed in a variety of ways to give almost a 3-dimensional appreciation of the location of the vessels, as well as certain abnormalities. And here we see the common carotid artery coming into the internal and external carotid arteries, and right here we see stenosis of the left internal carotid artery. There are other 3D reconstructions that are appreciated here using CT rendering, post-processing, and you can see the large middle cerebral artery traveling off the anterior cerebral artery, as well as brain structures that they might be involved in feeding. Magnetic resonance imaging uses magnetic energy, and in this case you can only see some of the larger vessels. You tend not to see smaller vessels, but you can see the middle cerebral arteries here, the anterior cerebral artery here, as well as the posterior communicating artery and the posterior cerebral artery, which is going to feed the back of the brain. In 2003, the Nobel Prize was awarded to Lauterbur and Mansfeld, who developed the MRI, magnetic resonance image. It uses magnetic fields, avoids ionizing radiation, and it induces a magnetic force on the body and then disturbs that magnetic force briefly and measures the radio frequency emission from molecules that have been initially aligned. That's shown here, a variety of molecules, particularly those that have bound water, hydrogen is included. If you put the body in a field that has a very strong magnetic field, all of those bound water molecules are oriented in roughly the same direction. If you disturb those briefly, as you might in a compass, when you hit the needle on a compass, it will gradually they'll all gradually reorient to the orientation of this field. and it's possible to detect that over the next period of time and show the relaxation of those molecules back to the point at which they originated. And in detecting those, it turns out that water and fat provide somewhat different signals, radio frequency signals. The resulting images are rather striking. They provide remarkable differentiation of gray and white matter, of the gyro pattern that you see here. As you can see, brain is, in this case, gray, whereas air and dense bone, we see the skull is all black around here. So on an MRI, dense bone is black. And moving blood is also dark because it does not have a sustained magnetic moment. But we can see the brainstem here as well as the spinal cord, cerebellum, and corpus callosum, and the thalamus right here. In MRI, there are a variety of sequences that can be used to see tissue somewhat differently. And we'll start off with just recognizing two major sequences, T1 weighted axial slice and a T2 weighted axial slice. And in this setting, a T1 weighted axial slice, the CSF is dark, as we see here, the CSF in the sulci, whereas in a T2 weighted image, you see that the CSF is all white. And in this setting, we can see that the scalp, which has lots of water, is light, skull is black, and that CSF, as we said, is white, and that gray matter is in between. And in this setting, gray and white matter are not very well differentiated. In the T2, they're somewhat better differentiated on the T1, as we'll see. Here's an excellent image of a T1 weighted image, and you can appreciate various structures and appreciate that the CSF in this case is black, whereas the brain tissue is lighter. On the other hand, on a T2 weighted image, we can see that CSF is white. All this area is CSF, and in fact, the vitreous in the eye is white because it's loaded with fluid. And again, we see the skin is very light because it has lots of fluid in it. We see here the midbrain, the cerebral aqueduct, and temporal lobe, and in this case, there happens to be a tumor that is loaded with fluid so that it appears white. We can appreciate anatomical structures when we compare an anatomical specimen with this high quality MRI image and recognize the caudate nucleus, the internal capsule, posterior limb, anterior limb, and the genu. We can recognize the thalamus, recognize cerebellum, temporal lobe here, frontal lobe here, the fornix coming down here, and occipital lobe here in the back. This is a horizontal slice through the brain at this orientation. The MRI, as we said, best detects structural anatomy, as you've just seen, a very good gray-white matter differentiation. But interestingly, the T2 image often depicts pathology best because many pathological processes have a very high water content and fluid is much brighter. If there's inflammation, you'll tend to see it much better in T2. There are several other sequences that you'll get to know of in the future, and those be very useful in making further differentiation of pathology. We see here now a series of tumors, and you can see the difference between a T1 MRI and a T2 MRI looking at the very same brain, and you can see a brain tumor that stands out like a sore thumb, and very subtly you can see it on the T1. You would hardly appreciate it when we're out here. Here we see a stroke in the distribution of middle cerebral artery. As we said, it covers most of the lateral hemisphere, and you see it over both the frontal and parietal lobe as well as over the temporal lobe, with both changes in the gray matter as well as changes in the white matter. Here we see an anterior cerebral artery stroke. See it in the frontal lobe most severely with a loss of tissue. And on the MRI, you see a very fine resolution of cortical structure and subcortical structure. But on the T2 weighted image, we can appreciate the level of inflammation as well in the stroke area. The MRI is also very useful in multiple sclerosis. And here we see on a T2 weighted image plaques that are in the white matter and in the periventricular area right over here. We see additional images. This is in a healthy brain, and this is in an individual with multiple sclerosis. And we see these indications of multiple areas of demyelination in the periventricular area in the white matter. We can also see on these different images of T1 and T2 weighted images, you see some indication at the head of the ventricles right here and here that we have abnormal tissue. That's actually the sclerotic tissue that is referred to in multiple sclerosis. It has multiple different locations. And then with the T2 weighted images, you can see the remarkable amount of fluid enhancement in those regions. We'll look at a number of MRI metastatic lesions, and here you see multiple lesions in the brain, both in the posterior portion of the hemisphere, a little more anteriorly, as well as in the opposite hemisphere. Here we see an MRI image of a lesion, in this case a meningioma in the frontal lobe, that had been resected previously, and we see where the resected area is CSF, that's just black, and yet the tumor starts to show up in this region right against the falx. A meningioma seen here in the frontal lobe can be seen both in an axial T1 image. You can see it because if you know the anatomical structure, but it would be hard to appreciate it. But if you look at the post-contrast inject material that will tend to highlight such masses, we see in this contrast material in MRI that you can see the tumor stand out like a sore thumb at the base of the frontal lobe, here and here. This is in a coronal section. This is in a sagittal section. This is in the axial section. So you can see the same abnormality in all of those different structures, in all of those different orientations. And this is a glioblastoma. You can appreciate that it's seen very well with an axial T2, much more poorly with an axial T1, but with post-contrast material that tends to enhance using an axial T1, but with the contrast material that tends to enhance a membrane around a portion of the tumor. In this pituitary tumor, we see using the MRI at the base of the brain, engaging both hemispheres, both from the coronal section as well as from a sagittal section, using an enhanced material to bring out the MRI abnormality. Here we see an MRI from a tumor that's in the temporal lobe. Here in the medial portion of the temporal lobe, remember we're looking right, that means the left, in the left temporal lobe, and this is in the hippocampus and amygdala. And we can see it here on the axial section, and recognize this is a T2 axial section because we see that the vitreous is white. And we also can see the same mass in these sagittal sections. MRI is useful to assessing atrophy, and here we see in a variety of different individuals, from a normal young, normal elderly person to somebody with mild cognitive impairment and somebody with mild Alzheimer's disease, that this tissue has shrunk. That's the hippocampus. There's a smaller and smaller hippocampus as you first appear with mild cognitive impairment and even smaller with Alzheimer's disease. You can also appreciate atrophy in the hippocampus in this person with epilepsy, but you also may see an increased signal in this image, and that will indicate a change in the tissue in that region. And you see it on the axial section as well as the coronal section. Here we see a patient with Huntington's disease compared to a normal. In a normal, you see a prominent caudate nucleus and a moderately sized ventricle. In the patient with Huntington's disease, we see atrophy of the caudate nucleus on each side. As a result, the ventricles are enlarged simply by the loss of tissue nearby. You may also use the MRI to assess abnormalities of cortical development. In this individual, we see gray matter in a location that we should normally see white matter. We see it on this sagittal section and we see it on this axial section. This should be all white matter in this subcortical region. Instead, there's a large area of maldeveloped cortical tissue in the white matter. Both CT and MRI are used widely. The CT is significantly cheaper and much more readily available. It is safe for patients who have metal in their body, fragments of bullets or other material from implants. It is a good first pass for viewing pathology, but it does have a significant risk due to exposure for radiation. So you don't want multiple CT scans, or at least you want to keep the exposure to a minimum. For the MRI, there is no exposure to ionizing radiation, and there are no downsides that are known to the exposure at this point due to the radiation itself. It provides much better resolution, more detailed view of pathology, and can detect some very subtle abnormalities such as cortical malformations, abnormal gyral patterns. It is much more expensive. Variables to consider is the resolution. Include the resolution. Spatial resolution is far better in MRI than in CT scans. The risk of invasiveness angiography includes putting a catheter up through vessels, and if it were not done well, you might puncture a vessel and cause a significant hemorrhage. Ionizing radiation is an issue for X-rays, for CT scans, for angiography, as well as for some other measures we'll talk about in a moment, the SPECT and the PET scan. The cost and availability are important variables. In general, CT is less costly and it's more available than MRI. Other modalities that are available now, but we have not discussed here, are functional MRI to look at various functions layered on top of the MRI, diffusion tensor imaging, also based on the MRI, single photon emission computed tomography, and positron emission tomography that provides measures of functional activity of the tissue you're looking for, and ultrasound. And increasingly you will see co-registration of functional and structural measures, where you'll put together a functional MRI and a CT scan and perhaps a positron emission tomography or a SPECT scan. A number of references you should consider, and particularly look at maps that show anatomy as well as structure on both MRI and histological specimens. Thank you.